So compassion 15, this is a representative of a class of agents, bispecifics. So already heard a lot about them during ESMO. This is a PD-1 CTLA-4 bispecific. AstraZeneca also has a PD-1 CTLA-4 bispecific. And so this was, again, compared against chemotherapy alone, not chemotherapy plus immunotherapy, but as the rationale we heard before at the time of design, this was reasonable design. So chemotherapy versus chemotherapy plus camomilumab. We've seen this paper previously published in Nature Medicine a while ago. Now we saw the mature results really confirming what we already had seen, but it is certainly nice to show that with additional follow-up, the surviving benefit has been maintained from the original publication. So that it's hard not to do cross-trial comparisons, although we're told not to, but if you stack... If you stack up that absolute numbers and the medians, it's comparable to what we achieved with chemo plus PD-1. But if you have the curves, I don't know if we have the actual curves, but one thing that is interesting and is seen with some other CTLA-4, and I'm quite interested to see if it holds out of PD-1 TIGIT, for example, is you do see a plateau and slightly higher proportion than what you see with chemo-nivo if you were to superimpose the curves. So there may be a subset of population that is a little bit greater percent of the overall that do have these long benefits with a PD-1 CTLA-4 bispecifics. I think that is a subset of patients that would be great to understand, because there may be a group of patients who actually do have greater benefit with the addition of CTLA-4 plus PD-1 blockade on top of chemo. And I think, Yelena in 649, even if you look at the Ipi-Nivo arm and then MSI versus the Nivo containing arm, you kind of see the same limb.
I mean, with even from checkpoint 32, which was the DOHP A-line study where we picked the Ipi high dose to go forward in the phase 3, if you respond to big duration responses double to Bopis cap and epic response, and also the issues that there are 2 patients, cultural variations from the initial checkpoint area 2 areas, cures despair. That is that happens. So I think having a feasible and well-tolerated CTLA-4 partner, that's just scares this must be very true. And when skin China and the whole
Yelena would do that. Don't banana mappa and say or the near map.
I think people what people often ask patients who mother cancer, the specialist, whenever we cure cancer, is asked cancer, and I think it will take all of these options in sequence or do different mission career position at different therapies. So in the future, I think people. So we know, for example, from check data, from biomarker data, we'll sort of see first check our bioresponse, but maybe now they get right, so we get T-Rex, software. Ideally in the future, will the body crystallize ID to go up feasible weight select mission. So for some patients, it will be anti-PD-1 alone. Some cases, it will be potential combination checkpoint inhibitor combination to the checkpoint plus anti-tumor target. So it's an exciting time to get into gastroesophageal cancer. We're planning on retiring, so we're not going to be working like some people at ESMO into the 70s. So there'll be room for you all to grow and develop the field. So Amali, what's next?
PG, PGX,
yeah.
So, what is your as
Okay. Well, what do you want to talk as a chapter and then now with as in home? What else should we cover? Should we talk about FGFR-2b?
Of course, yes.
So we can tell that you will discuss the data. Okay. So on Monday in the presidential session, we will see for the first time a randomized clinical trial on FGFR to be targeting with marituximab and chemotherapy versus chemotherapy alone. So this is the first 101 study. Of course, we can anticipate the results because the results will be discussed tomorrow. That this is coming from a very precise story starting from phase 2 randomized trial, and the biomarker selection of the cutoff for positivity, designing phase 3 trials, 42-101, 42-102. So, of course, we read the different press releases, you also paper data. So I wanted just to add your thoughts, even if we can disclose the results. But of course, we will be all there to listen to your discussion because I think it will be amazing. But yeah, what do you think about the future development of FGFR-to-be targeting?
For great background, you need more biomarkers. You heard about HER2 a bit, and that's an exciting biomarker where, because of that biomarker, more and more development is happening in gastroesophageal cancer. We have, of course, PD-L1, Claudin, or expression of very party, and MSI. Those are the first core sort of important steps to understand where the tumor is going with it, but it's still development. And FGFR2b overexpression, but also FGFR receptor aggregation, can happen in gastroesophageal. So the Fortitude study looked at bemarituzumab, which is a antibody that targets FGFR2b in combination in first step. You know that not every antibody is created the same. Some antibodies have synergism activities that others don't. Or just map in selected patient population using patient pushback as single agent active. So that's the PTs. And we had exciting data. I think, Sam, did you participate in the fights?
Not in fighting, but for
Fortitude, yeah. So Rizan has also been on the steering committee. So, but you know, the fight study where we saw those kappa markers has a ratio of 0.5, which is not perceivable of whole fox, using the higher FGFR cutoff of 10% and IC2 plus. It was a very coordinated step forward. You this population of patients that otherwise going on or two bought in kind of new truth. So tomorrow, you know, it's supposed to be a decided presentation by Dr. Ra, presidentials late the evening on the last day of ESMO, but I would stick around and Sam, maybe you know, someone in sort of honor Gageta and comment on the cheats to see.
Yeah, sure. First, I'll make a comment on biomarkers since I know there's some trainees in here. You should read everything that this guy, Dan Hayes, writes. He was a breast cancer oncologist at the University of Michigan, but he wrote a paper in JCO like 10 years ago about what does it take to get the biomarker good enough, and I think this will be relevant to the FGFR2b story, which is what I'll mention it, but there's two essential components. One is analytic validity. Can it be reproduced reliably and at a cutoff? And I am not sure that that is true of FGFR2b because the antibody has been rather proprietary, so there's not a lot of comparisons out there, although there is getting to be more and more publication. And then the second is it clinically, does it have a clinical utility, which is, did the patient do better because you use the biomarker to select? And those are two fundamental properties for any biomarker. And again, FGFR2b at the current cutoff probably includes all of the patients that benefit, but may also include some population that don't benefit. And so there's probably some refinement to thinking about how to select these patients beyond what was done, although what was done makes a lot of sense based on the fight data. The toxicity is another issue. I mean, certainly implementing new drugs, and we've learned this with Claudin drugs as well. Any drug that has a class-specific toxicity is going to be a learning curve. In cholangiocarcinomas, where they have FGFR2 fusion and TKIs, learned a lot about phosphorescent diets and these nail changes and stuff that have gotten better. FGFR2V inhibition, as we learned over the years, is associated with several different corneal toxicities. And these patients require baseline and relatively thorough ophthalmologic exams, which is always the easiest thing to do. The good news is that the toxicity when you hold the drug does appear to be reversible within about a week's dish, seemingly from what's out there publicly. But the ophthalmologic findings can persist for quite a long time. And so treating to ocular toxicity or seeing some of these things is definitely a new thing we'll have to learn how to do. If this half-away ultimately becomes something that's approved, I think we'll all wait to see the data of this phase 3 to think about what the path forward is. But ocular toxicity is a real thing, and it can be bothersome for patients, just like nausea can be bothersome for patients with clotting drugs. So definitely some experience that we'll all have to gain.
Yeah, and definitely with the new drugs, the problem of the toxicity is improving. For example, with the novel ADC, I don't remember the name, and BGB something. But anyway, with his agent, it was demonstrated at least at a clinical level. There was a poster at the ACR that actually based on the mechanism of action, even though this is an AEC and not just a non-covalent antibody, the ocular toxicity issue is definitely lower, is not an issue. So the drugs are improving. And also I take that 4211 is the first piece of the puzzle, because we would have to wait for the results of the larger study, 42102, this more contemporary study, because the control arm is actually chemo and larger sample size. So we would have to put everything together, but I think that FGFR-B is an important target. We would have to work on this. There is a group of researchers, including you, working on the heterogeneity, special heterogeneity of these markers, and also Koishitara in Japanese work around on the overlap with these 5 markers. And it really seems that there is no people overlap, at least as far as I know, HGFR2B and other markers in the beginning, including claudinic TP2.
Yeah, that's OA's work primarily. Yes, if you use the cutoffs that have been published, there does not appear to be specific enrichment among other biomarker groups. It's a little bit like Claudin in that way, where it's sort of, there is, kind of runs through the other groups at a relatively stable prevalence, but outside of MSI, where we really don't see as much Claudin or as much FGFR2, kind of runs through several of the other groups.
Yeah, and we should remember that sometimes it's also analytical problem, because if the tissue is taken, for example, 3 or 4 years before, so there is antigen loss, and so you can get negative results or lower expression or popular expression, but at the end of the day, if you are going for a new biopsy, probably on the metastatic sites, you're gonna get these partial results and positive results, and making the patient eligible for the treatment. So nowadays the trials are really putting some restrictions in the inclusion and exclusion criteria. And for example, the tissue must be taken a maximum of 2 years before the enrollment. And this is annoying, because otherwise we may face the same problem: heterogeneity, loss of expression, temporal heterogeneity. So is this something we should take into account?
And I think also, Bridget, think GFR2 is important.
But for me, the one thing that
does give me a little bit of pause of a picture because ocular toxicity is not something that we as medical oncologists are good at recognizing or following. So I was not a per one study, I was per 102. So, and so probably below first thing lesions per the dry eyes, and then that's followed by over time keratitis. But I don't know how good you guys are at slide down exams. I had no so good at doing. So me that they have to go to ophthalmology as time class. And so to me, the one thing that was difficult in cataract, right? People say, Anna, it's easy for you at Princess Margaret. You can call your ophthalmologist, they're gonna see a patient, tomorrow. And you would have Corneal. But what are we gonna do? Unity.
Yeah, so it's definitely a real problem. I mean, we in Boston, we're physically next to the Mass Eye and Ear, and we can send people, but most of our patients come from New Hampshire and Maine, and they're not even ophthalmologists. So I just ask patients how they figured they're building on their yes.
Yeah. All right. Any questions from the audience? Please.
Yes, Annie, there are good results. I'm a practicing oncologist in the USA, so the community oncology, including a large number of. I'm sourced from the United States, so I have a community oncologist and a pretty large number of GI. The question, is a little bit unrelated, but I wanted to ask your opinion about the capecitabine plus cirrhosis maintenance platform that was in the ASCO recently after a basic induction for SR disease, and particularly if you could maybe mention few applications in signal cell morphology of the cancer. I see that quite a bit. Thank you.
Well, Phil, as Armani study, I think, is the most relevant study to quote in this. Please tell us about Bill Agrakis is in the one, and of course the study is held very appropriate there. Armani, this is an investigator initiated study, very innovative design, so please tell us.
Yeah, basically, before we had the opportunity to use monoclonal antibodies, and except for trastuzumab, so before the immune checkpoint inhibitors, maintenance therapy was probably more in the area gastric cancer. But coming from colorectal cancer research, of course, we designed this trial called Armani, not just because we are a fan of fashion designers, but maybe yes. Could I say? Maybe that was the reason, but the aim was really to allow the exposure to all active agents in the therapeutic group of these patients, because we know that when we gave adjuvant-based chemotherapy to these patients, actually secondary resistance to chemotherapy is really quick. And so even in clinical trials, 40 to 50% of patients were able to receive actually secondary therapy. And in the clinical practice, probably the percentage of these patients was even lower. So the design was easy. Basically, patients with disease control after 3 months of osteolytic chemo were randomized to either continuation versus early switch to cellular demonstrative separate regimen architecture and COPA. And this provided a significant benefit in terms of progression-free survival, which was a primary point, but also the key secondary effect of overall survival. And now there is a proposal for the design of the Armani 2 study. I cannot really disclose the agents used in this trial, but you will find it in clinical trials in few weeks. Well, okay, I think I can tell you that people the osteolytic-based chemoplastis, the rizumab continuation versus the switch to paclitaxel and ramucirumab, is the rizumab. So this is a contemporary study with the use of immunotherapy. Of course, in the clinical practice, we do continuation maintenance because we continue immunotherapy until disease progression or for a total duration of 2 years. It depends on the response, tolerance, etc. And sometimes we can also continue the fluoride backbone. So, for example, here there was a poster looking at the potential continuation of the fluoride component, capecitabine, after receiving double chemotherapy plus tislelizumab, and actually patients receiving capecitabine and tislelizumab had the best outcomes. We really don't know because actually the benefit of adding tislelizumab was observed irrespective of capecitabine continuation or not, because of course the magnitude of benefit is given by immunotherapy and not by the chemotherapy continuation. But anyway, continuing chemotherapy may be useful for some patients with good tolerance to the fluoride backbone, and also maybe an option for these patients to prolong the duration of disease control. Anyway, we should really discuss with our patients on what to do after the induction phase, because of course we have to discuss the potential toxicities, the pros and cons, and the expectations, the number of hospital visits, and how they are really willing to continue chemotherapy, or some of them may just go for maintenance with IO alone, and this is really good. Maybe the DDR1 value is high, and so they are really satisfied with IO continuation alone. So it's really a discussion, and it's not just black and white, because sometimes we can continue capecitabine plus IO for some months, and then de-escalate to IO alone. There is no single rule, so we should always remember to discuss with the patient and share with them which is the optimal decision, and it's not just in a single time point, because we see the patient several times, so we can discuss how to really modulate the maintenance. Nowadays we have continuation maintenance, but for example, trastuzumab, pembrolizumab, what do you do? Do you give based on the 811, let's say, do you give just the combination of the human and non-human antibodies, or do you give a fluoride?
Yeah, I think fluoride are so important in this disease, and our patients are unique because they always want to continue. You have patients continue every few years now onto this. In fact, I think an escalation strategy will be very big. In fact, we follow them very carefully with even the patients with prolonged disease, there would be fluoroscopies, trying to catch the disease before it progresses. Clinically neat regression, such as ascites, and it does, I think, impact patients' quality of life. Sure, continuing therapy, but so does disease progression and now to escalate, right? So I think most patients are relatively fit and want to have such a suppression, oral capecitabine, and every 6 weeks therapy or every 4 weeks therapy.
So when do you stop? Let's say in LFI, patient 5 years on Herceptin, Pembro, K, and no evidence of disease, and now they want to stop. Obviously, so there are indications because often key stops, punchy, expire,
No, well, that's for sure. I mean, in clinical trials, absolutely, we stop after 2 years, unless it's MSI tumor. We don't just stop routinely. And in MSI cancers, often it takes longer to convince someone to stop and use it than than to continue. But we do discontinue therapy. For HER2-positive disease, I've had patients on the initial phase 2 for undershot. There's still 1 or 2 patients still on. It's just very difficult to continue. And again, our patient populations, they are highly metastatic and scared, and then they come in with complete response. They vividly remember, even it goes 5 years ago, what done cancer look like building right in that space. So we don't typically stop, and that's why I think it's strategy or a really definitive biomarker to try to de-escalate. CMD is okay, not great. Imaging obvious is okay, not perfect. The metastatic disease, we just don't have a way to capture it. What else? Please, go ahead.
Trying to be, I'm a practicing oncologist in Armenia and I do values in GI and sarcomas. And my question to you is more like just your thoughts and understanding. What are you most waiting for? How do you see gastric cancer regimen changing in like 5 years? What do you see will be the next updates and approvals? With so many biomarkers and new drugs approval, we don't know how to sequence even them. With ladies on leukemia, like no one knows or how to start, how to go.
Yeah, so the next 5 years will be really moving many of our treatments and breakthroughs into perioperative setting. And as Sam would really attempt to focus on gunshot clothing, scary cartridges. I think treatment de-escalation, as appealing as it seems to be, we're not trying to for that yet, and a lot of it is escalation and focusing on systemic disease nature of this cancer. We know that most patients hungry they recur for metastatic or localized disease. It's always systemic disease where we battle is lost, right, for metastatic patients and for lung gap patients. So focusing on perioperative setting and pushing that envelope is what many of us are excited about. We'll collaborate together to answer these questions quicker. I think the next phase will be using some digital pathology and machine learning to try to expedite biomarker testing. So not how you wait for, even if it's just eight different immunohistochemistry biomarkers, doing first and work these results from scan HV, so that we won't have to wait for actual tissue many to look at some pathology. That's probably 5 years, no longer. And hope, I'm particularly hoping for is to try to tackle chemotherapy refractory subset of patients, perhaps using theranostic agents or other forms of systemic giving away radiotherapy. This radiation, unfortunately, as a whole is non-prescribed. These are other ways to target some of these biomarker the population using more ingredients turned off. And the patient comes in and we accept the fact that some of patients may not want to have their esophagus or stomach out, and that's okay. We understand that they need to be really all in for watchful waiting, because that's a pretty involved process as well. You need to be able to come in every 3 months, get a PET scan, and that's reviewed. So, and I've done this now on several patients, even before the FGFR study. Usually it's patients who are maybe octogenarians in their 80s and really don't want breast operation very medically and location. And I wouldn't rush to radiation either. We usually start with either doublet with anti-PD-1, FOLFOX type regimen, or if they're a fit patient, even we'll unit dose reduced plot plus IO. We repeat, we would get to the maximum pipe response in the repeated endoscopy. And you'd be surprised in some patients you don't see clinical response, complete response per repeated endoscopy biopsies negative. So in that case, I don't see a compound reason to radiate because what do we calculate being there? The only reason we'd consider radiation if there's residual disease, no evidence of lung, metastasis to residual disease, so forth. This is a rare population of patients, but it does occur, and we know that even in checklists for 9 and there 11, it wasn't up studies, so forth, questionnaire studies, our population with adeno will have BP response outside of MSI, outside of PL1 by PD. And that's decided in each stage journey is the journey. I actually don't disagree with them that when the gastroesophageal cancer the rate of recurrence historically is so high that rushing into surgery and perhaps giving, chance of the disease to declare itself, right? So doing 6 months or 8 months of immunotherapy is feasible option.
Thank you for the nice session and congratulations about that one. I want to ask you in the day.
I know who you are.
I'm Enes Yeşilbaş from the same hospital, we are colleagues. I want to ask you that in the patients who we achieved pathological complete response, should we continue in adjuvant setting, dual or continue the isolation?
So the question is, have a white T0, N02 or after flat Durba, what to do in adjuvant? So the standard right now, I think outside of strawberry and subgroup analysis and so forth, standards to continue therapy. I know there's some retrospective data that suggests that there is non-responders or patients with complete response and maybe less benefit, but you have to remember this is not in the power of subgroup analysis and it's unrespective data. And the way that I practically think about it is the impact of micrometastasis, especially the primary tumor, maybe to separate the vascular disease. So again, my decision was not based on pathologic response, although that's helpful to the patient. Sure, it's based on location most like. You look at is their therapeutic tubes, what percent the body weight have been lost total, and they back to eating normally or their version of normal, right? They understand that be it the T small or big DS and so forth, and time after the recovery period. So typically we see it out 4 or 5 weeks post-op. We see how they're doing, and then typically they're not quite yet ready, but they're yet ready. We kind of do a pep talk about what to do, how to get better at certain things, and then they come back a week or 2 weeks later to resume therapy. And again, more of a clinical decision of whether or not additional systemic therapy should be given. I don't think we're quite there yet. I mean, even with tools as ctDNA and so forth, sensitivity of tools is not quite sufficient for us to put therapy. And the patient that pose the body disease are high risk.
All these mobilized spices or what. And now, when I'm standing here, we see a lot of them going on phase 2 and phase 3, but it takes time. And before it gets to the approval, it will take even more time. So how do you think we should design the trials so the approvals are earlier when there is good luck there? Do you think that it matters? Or you design a bit was around and all the experts and we're just started and we're just watching what you do, but this actually takes how good the results can be and how interpreted will be, how you choose.
Well, so we had the ICE representation with Sam, he's on that to Sam guidelines. Oh, now this group was from Canada and the group was in Italy and the UMA.
So I would, before we start with that, I would say what I find more frustrating as a researcher is not that the lack of approvals, but a lack, even when the drug is approved, the lack of implementation of these agents to just an average person in an average country. And the fact that it's true, some countries still don't, test there too. Lontrastuzumab has been available for maybe not even for 15 years. Plus, it's probably the hardest part for me to stomach. And that's why I never turned down the opportunity and education opportunity to talk about gastrointestinal subgroups.
It sounds like other patients come and find me in Canada when the Power Translated first came out. I think, look, I chatted with you about that patient to get it in the United States because of
So for us, Bandik is only true, but such as that inner me, skin to bag, going out, but yet. I think the bar to finally see what care system is just slightly different. I think we also get Kakashi access programs, but there is a damage this last year. that's realistically what happened with it. I know in the US you guys don't have to deal with that, but ever since I've gone back to Canada, I had to deal with this. I think for me, I think the cases of Mercator are very smaller. So I think the future of how we develop these problems, how does the patients faster, is maybe these performities getting together and doing more platforms for trials or something like that. I think that would be exciting and different, right? And I think understanding the translational stuff is what's.
Yeah, for me, doing academic research is the goal, and when I find a pharmaceutical company keen to fund academic studies, I really appreciate it, but because I think that this may really and may trigger some developments, especially in early stage disease, because we know very well that the drug development start from chemorefractory disease, pre-treated patients, and then going up to the first line, and then the life cycle of the drug is almost over, terminated, where we go to one of the most important parts, the patients with curable disease, and then you miss the opportunity to apply the use of these agents to efface the trials in early stage disease. So going concomitantly to academic proof of concept trials in early stage disease, it's happening because the cancer. So basically, I think this is a good opportunity for seeking signals in academic research and not missing the opportunity to inform the design of phase 3 studies. For example, the example of the Inus 585 is really important because there was no molecular selection, there was no UV flood, several issues, and actually the matter was a positive study and changed the clinical practice. But this is an example, so we should really try to collaborate with the industry because as academic researchers, the collaboration with the industry is key to really get those drugs in those patients who had curable disease, because of course we want to cure more patients in the future.
Yeah. Maybe I'll take a tiny little piece of that question and would encourage anyone to check that session out from yesterday. But there was a session on optimal perioperative various eyes and what we can learn from other tumor types. So head and neck cancer, there's been a very nice trial. The breast cancer, the went to Röntgen, all I-SPY trials, a surgeon gave a wonderful talk about using this as a framework to test surrogate endpoints. And so there's some tension between, like, the FDA just issued a statement about importance of using overall survival, which of course is ultimately the most important clinical outcome. If we can, as a field, work towards validating the surrogacy of some of the earlier readouts, we may be able to, as you suggested, get closer to execution. Filippo, the nice project that you're looking at PFS and OS surrogacy. These kinds of things add up, and eventually it ultimately is a discussion of regulators whether they accept that. But in other tumor types, there is a precedent for some of these surrogate endpoints as a tool to potentially get drugs earlier. But we don't have clean guidance, right? So free.
So I'm like a student interested in oncology, and I would like to ask you, when we talk about GI cancers, do you see the role of cell therapies in the treatment of gastric cancer?
Well, CAR T cell therapy, the first saw tumor in gastric, the positive study was in second-line therapy. And it's certainly, also out of China, it's a very, it was an exciting step forward, but the median difference in progression-free survival against standard later line therapy, chemotherapy is very, so I think we want to say that CAR T is ready for some form of, so their cell therapy would be the standard in gastric cancer. In my lifetime as an oncologist, I think practically would have to be more off-the-shelf therapy such as T-cell therapy or other versions of subgroups. First of all, in our disease where cancer progresses relatively quickly and the disease we're not is eliminate, start to wait to make a bespoke therapy will be, and also of course the cost, and then delivering it to the average patient in gastric cancer. Because we all hope that what treatment that you develop and they thought of and you pushed so far to bring it to the clinic actually helps people outside the little radius of Valkyrie study, and that, which is really important. So in short, I think it will, but not in the current standard. We have to really take the car apart and then pick up something else, maybe an airplane. Please go ahead.
I'm Selma, I'm from Morocco. And yes, it's very exciting to see all of these new molecules and these new drugs. And I know that this will, they will be accelerating in improving survival of patients. But what about financial toxicity? And I saw that there was trials that tried to answer these questions. For example, in breast cancer, there was a trial trying to see if in reducing the number of cycles of trastuzumab, if there was any impact on the survival. What about gastric cancer or any GI?
Financial toxicity, especially in the current climate all over the world, where the hospital systems are getting bankrupt, is so important. I'll share with you one of the revelations I had at this meeting is when we were going around the table discussing a very complicated regimen that many investigators in the room thought it was feasible because you could just admit a patient and give this treatment in the hospital. But the truth is, while many hospitals in the United States and Japan and others are going bankrupt because they cannot admit enough patients to sustain these chemotherapies and treatments are so expensive. I am very worried about the cost of research because the companies have to spend so much per patient on each individual patient, upwards of $30,000 for each patient enrolled in these centers, that for them to recoup many of their R&D funding and also keep going with their development, they can't sometimes help but charge maybe too much for the drug. AstraZeneca just recently downsized their footprint in England because it was, not financially favorable to them to, and that's not good for the collaboration with the investigators and CREK and others. I'm worried just like you. I think there has to be a better way, and I think the popular line has been hospital at homes. We're going to turn everything to oral therapy. Everything will be cured with a pill. That's clearly not the case. As Amada said in the question back are these treatments are getting more and more complicated, or side effect profile. If you have to have an ophthalmologist and an oncologist to get once a monoclonal antibody that may or may not improve survival, it becomes complicated. So I don't have a solution, unfortunately. But I think talking about these points is the only come on.
I think the financial toxicities one thing, there's a group called Choosing Wisely, and you may be aware they're here as well. And also ASPA, right? It's recommended that we shouldn't be thinking about cost of drugs. I think the second part of this is toxicity. And so I think in incorporating this into clinical trials, in some ways it burns because it is toxicity does affect patients, right? There are certain drugs they have very long chair times.
You have to be admitted and reach out for some of it are.
So to go back to the cell therapy question, and two cell therapy trials, we had to get trained to administer it because our hematologist could analyze HER2 and Claudin. I think there's really toxic. Only a few patients could actually go the cell therapy is owed to. I mean, I think that is extremely extensive. It's your, something you aspire to for sure. Do I think it's going to work with solid tumors? Like it doesn't work with tumors? I'm not sure. I'm actually about probably studying about aspects. I think that's going to have each application. And mostly because plus you can visualize where these blood status.
Sorry. I think it's important just from a point of view of sustainability of our therapies that financial toxicity also affect individuals because sometimes they have to travel. So they spend money to travel to bigger hospitals of different cities and they have to pay hotels, trays, place, food, everything to get access, not just to trials, but also to novel therapies. And so next this is possible in different hospitals, different regions, different countries. So this is also an individual huge problem. So I think that we should really talk about global access to novel therapies, not just from the point of view of sustainability of the national health system, because, for example, in Italy, you have free access for everyone. And this is not going to be sustainable anymore because, of course, cost of these combinations will be not sustainable soon. But also from the financial point of view of families and patients and their caregivers, of course, this is important. So when we measure quality of life, we should also measure not just what patients are getting in terms of quality of life, but also what they are losing in terms of time spent at the hospital, money to get access to these treatments, and so on. So I think that the problem is really useful, and we don't catch it in the clinical trials, actually.
Speaking of travel and quality of life, I think the evening is getting close to an end. Maybe we can close the session, and unless Sam, you wanted to say.
Oh, I just have a small comment. Coming from Morocco, so I have an oncologist with me for a year from Thailand, and there are some very practical things that actually can be done. So most monoclonal antibodies are initially developed on milligram per kilogram, and then we realized that most of them can be dosed flat dosing. But Thailand, for example, an average person weighs like 50 kilos, and the average American weighs like 80 kilos. And so you actually can get away with like half the dose of one vial of Pembro versus 2 vials of Pembro. And it winds up chipping away at some of these little cost things. In India, they did a study at neck cancer of like 1 vial versus 2 vials. No difference in outcome. So there are little pragmatic things that can be thought.
Yeah. And in Italy, we had this articulation bacteria 10 years ago. We had just the volume of day, where all the patients scheduled for receiving the volume came the same day, let's say on Monday. So you were going to save vials, putting all the patients together in a single.
You took up deep sea, which is quite a sense, at least what sounds.
Right. Well, good practical tips. We'll continue the discussion after the session. Thanks for your attention, and we'll find the questions.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.